Hi everybody, and welcome to the first part of your syringe driver training package. When you've worked through this theory session, you then need to view the video showing the practical demonstration of how to set up the syringe driver. In this particular PowerPoint, we'll be looking at some objectives and learning outcomes. We will look at why we use a syringe driver, in what situation we would choose a syringe driver rather than giving patient medication orally. We're going to look at how we talk to a patient about gaining consent. We're also going to look at how we insert the Saf-T cannula and how we manage that cannula to ensure that it is as effective as possible for as long as possible. And then we're going to look at some of the items that we need to be aware of when setting up the actual syringe driver, such as how we draw up the medication and that sort of thing. This is also obviously covered in the practical demonstration on the next video. So the first thing we need to do is we always need to be aware of our professional standards of practice, and we need to ensure that we are always working to these main standards. As you can see there, prioritising people, that we are practicing effectively, that we are always preserving safety, and that we are promoting professionalism and trust. And I just wanted to highlight this last one. And I just wanted to say that if you're not happy with setting up the syringe driver for whatever reason, you always need to discuss this with the prescriber, and you are in your rights to not set up the syringe driver until you are sure that everything is correct and you are happy with everything. Because at the end of the day, you have to justify and rationalise why you're setting up the syringe driver if anything should go wrong. So you need to be happy in your own mind that everything is in place and is the way that it should be. The other thing I wanted to discuss is that there's been a myth around for some time, and this myth is that a patient should have at least 3 PRNs before a driver can be started. This is not the case. As you can see there, if a patient has been on any of the following medication, either regularly or regularly PRN, they need a syringe driver as soon as they lose their oral route. And these medications are opiates, benzodiazepines, antiemetics or anti-seizure medication. And the reason that there shouldn't be a delay in the setting up of the syringe driver in this situation is that these medications are obviously there to control patients' symptoms. And if they are no longer able to take the medication orally, then we need to make sure that they continue to use that medication. So the way of doing this is to set up a syringe driver. And the other reason we don't need to wait to have 3 PRNs is because we know what doses to start on that syringe driver. For example, whatever dose they've taken of morphine in the past 24 hours, we can switch that oral dose of morphine to a subcutaneous dose, and that is the dose that we start with in the syringe driver. That way we can ensure that patients' symptoms continue to be controlled. There is one area that this rule does not apply to, and that's if patients are so medication naive that they've never had any of these drugs before. So this is the patient who's only ever taken a few paracetamol, but then they come under your care and their condition is deteriorating, they're starting to get symptoms. So by giving PRNs as they're needed, we get an idea, A, if they're actually going to need a syringe driver, and B, what sort of doses to start that syringe driver at. What we don't want to do is underdose a patient as much as we don't want to overdose a patient. By having a couple of PRNs before we start the driver, then we can see A, if they're going to need a driver at all, and B, what doses to start at. But the important thing with this, and I think this is an issue that the myth has sort of caused, is that we don't want to delay the commencing of the syringe driver. So nothing we should do should delay the commencing of the syringe driver. So we then move on to why we would use a syringe driver rather than other ways of giving medication. So the first thing to look at is that a syringe driver is just another way of delivering drugs, delivering medication. And its use comes about when the patient is no longer to take medication orally. And this could be for a number of reasons, as you can see in this list. It can either be a physical difficulty in swallowing the medication, or it could be a symptom that's causing the medication not to be absorbed. So things like persistent nausea and vomiting, if we're giving oral medication to somebody who's constantly vomiting, then we have no idea of how much of that medication is actually being absorbed. And equally with intestinal obstruction, where there's obviously a malfunction of the bowel, and this may also stop medication from being absorbed. But equally, one of the biggest symptoms of intestinal obstruction is nausea and vomiting. So again, we don't know how much of the medication that we want the patient to have they're actually getting. And obviously, for a lot of us, we come across syringe drivers for patients at the end of life, where again, they are unable to swallow due to weakness or some physical issue that's stopping them from swallowing their medication. But usually at the end of life, it's very much about weakness and levels of consciousness, and trying to get them to take oral medication is not possible. So there are a number of advantages to a syringe driver. The first of which is that we can get a steady plasma concentration of medications. So this is what we're aiming for. This is a steady level in the blood of the medication to control that patient's symptoms and ensure that they're as comfortable as possible. In the long term, there's going to be a reduced need for repeat injections, so we're not going to have to give regular PRNs because we've already trying to reach that steady plasma concentration. This may take 1 or 2 days because we need to make sure we're giving the right doses. So in that first 24-48 hours, PRN doses may be needed just so that we are fully aware and fully able to reach that steady plasma level where symptoms are better controlled. It is going to provide better symptom control for things like nausea and vomiting, because we know that by giving the medication subcut through the syringe driver, the patient is going to get the dose that we want them to get. And equally, because we use a number of drugs in one syringe, that could hopefully control multiple symptoms with just one syringe driver. So for example, if the patient's got a syringe driver with midazolam, levomepromazine and buscopan, that's going to control restlessness, it's going to control pain, it's going to control nausea, and it's going to control secretions, hopefully. So it's a very good way of controlling a number of different symptoms. And the other thing, from a practical point of view, if everything's working as it should, we only need to reload that syringe driver once every 24 hours. And because of the size of it, so if a patient is using the syringe driver just for symptom control and they're otherwise up and about, then their mobility is not going to be affected, because the syringe driver that we use is easily tucked into a pocket or a bag and can be used, so the patient can continue to be mobile and independent. So when we look at a patient starting a syringe driver, one of the things that's really important is to obviously get some sort of verbal consent. In order to do that, we have to provide that patient and their family with as much information as possible. And some of the areas that they may have questions about are, obviously, they might need to know, well, they do need to know, why a syringe driver is required. So it may be about discussing their condition and the fact that they're not able to swallow their medication, or it may be discussing the fact that the oral medication they're taking, because of their nausea and vomiting or their bowel obstruction, isn't working properly. So a syringe driver is a better way of giving that medication. We are going just to talk about how the pump works. The patient and family don't need to know how the pump works, in the fact that they're not going to be asked to do anything with the pump. But what they do need to know is that if the pump alarms, They need to know what number to ring to get somebody to go round and deal with the situation. Patients should not be asked over the phone to try and resolve the problem themselves, because we don't know if they do that whether they've done it correctly. So we don't know if the syringe driver continues to run or if it's stopped or whatever. We also need to discuss the drugs that we're going to use, and we need to highlight the fact that the drugs that we're using are very similar to the drugs that they've been taking orally, and the doses have been changed so that we can give them through the syringe driver. Sometimes patients worry about the fact that, you know, we're just giving them lots of morphine at the end of life, or we're giving them too much medication. We need to explain that that's not the situation, but sometimes if they've been taking oral medication and it's not being absorbed properly, once they are put on a syringe driver, those doses are absorbed better, so there may be some side effects. So they may feel a bit more drowsy for the first 24-48 hours, but that should soon pass. And because we're reviewing that syringe driver on a daily basis, these things can be picked up and managed as needed. We're always going to give time for questions, because that patient needs to be able to ask any questions that they want to, so that they feel comfortable with their decision. And also it's important for them to know that we're not just going to put the syringe driver up and then not come back. When I was working clinically, I would always, if a syringe driver was commenced, I would go back every day for the first few days to make sure the dosages were right and the dosages that we were using were working for that particular patient. And then at the end of this discussion, we can ask the patient about consent. Obviously, if there's issues with mental capacity, then that decision may need to be a multidisciplinary team decision. But again, we're always going to make that decision in that patient's best interest. So the first thing we do when we've got consent is we need to put our Saf-T cannula in. And on this diagram, you can see the ideal places to put our Saf-T cannula. However, this diagram is not always the same as the patients that we are looking after. Often our patients are very cachectic, so they have very little body fat. So it's about finding the correct and the best position for the cannula on each and every patient individually. There are areas that we need to avoid, and we need to avoid any areas of skin where the integrity has been damaged, and these are some of the reasons why. So for example, irradiation, we obviously don't want to put it in a skin fold or an area where there's constant movement of the limb. So for example, you know, near a joint, because the cannula may get damaged. We also don't want to use things like edematous areas, because if you put a needle into an edematous limb, we're just going to get problems with leakage, and that's going to cause more problems with trying to get the dressing to stick. But equally, you know, the drugs may take longer to be absorbed into the system because of the edema. And also with ascites, we want to avoid areas that are going to cause further issues for that particular patient. So when we're looking at inserting our Saf-T cannula, you can see the picture of it in the top right hand corner. All it is a plastic tube with a metal guide wire. It is a non-sterile procedure, so the idea is that we wash our hands and use non-sterile gloves. There are two sides to the cannula, and it's the textured side of the cannula that should go to the skin. In our policy, it states that the cannula should be changed every 72 hours. But as long as we can maintain the fact that the driver's running to time, there's no sign of redness, there's no pain, there's no hardness around the site, then we can try and maintain that site for as long as possible. We're going to, once we put the cannula in, we're going to cover it with a clear dressing, and it's good practice to write the date of insertion on that dressing so that the next person comes along can see when that cannula was inserted. And then what we do is we put when we put the cannula in, we put the dressing on top, and then we put gentle pressure on top of the cannula as we pull out the guide wire, and this comes out quite easily, and then the needle is covered by a plastic sheath, and that's just disposed into the sharps bin. I have heard instances where the syringe driver has been disconnected in order to give PRN medication. That is not good practice. That is something that should not be done. If there's a need for PRN medication, we would suggest that you recite a further Saf-T cannula somewhere appropriate so that you can give the PRNs through that second Saf-T cannula and not keep disconnecting the syringe driver. How do we manage the Saf-T? So as I said to you before, it's about trying to manage the Saf-T so it lasts as long as possible. There's a number of things that we can do. So for example, if you've got if you're starting off with a 20mm syringe and you're finding that you've got cannula issues and site reactions, you can switch to a 30mm syringe where you can add more diluent so the drugs are more diluted. Think about working on a drug concentration of around 50%. So for example, in a 20mm syringe, which you make up to 17 mils, if you've got more than 8-9 mils of drug, then consider switching to a 30mm syringe. If you've got less than 8 or 9 mils of drugs, which is probably more common, then you can carry on with the 20mm syringe. But again, if there's issues, it may be worth changing the diluent from water for injection, which is our normal diluent. Sometimes changing to normal saline can help maintain the cannula sites. And we're always monitoring our site. Each time we visit the patient and check the syringe driver, we're monitoring the site for any inflammation around the cannula, any pain at the site of the cannula, any hardness at the site of the cannula, and whether the cannula is leaking. And that's why we use a clear dressing so we can clearly see the insertion site of that cannula. What we want to avoid is a situation like this, where you can see the area is red, it's swollen, it looks like there's probably some fluid around it as well, and also with that particular dressing there's no date on, which obviously is not good practice for our trust. So we've got our cannula in situ. We've chosen the best site for that particular patient. So now we are going to prepare the syringe. I'm going to just go over the 7 rights of drug administration. So the first 5 that came out were, as you can see, right patient, right drug, right route, right time, and right dose. A 6th one was added, the right chart. And this is really important, especially if you've got 2 syringe drivers running. In some areas, you may well have 2 syringe drivers running. If that's the situation, what I would suggest that you do is each syringe driver has its own drug chart, and you put on one drug chart a coloured sticker, so a red sticker on one drug chart and a blue sticker on the second drug chart. You put a corresponding red sticker on that line and on the syringe as well, and you do the same with the blue prescription, so that you know that if you pick up the red chart to change the red syringe driver, but the syringe driver you've got has got a blue mark on it, you've got the wrong syringe driver and you need to switch it for the red syringe driver. It's just a very easy way of recognizing the 2 drivers. So that there has been instances in the past where one driver has been changed and it's been changed with the wrong medication. So when it was checked, the patient had 2 syringe drivers running with the same medication in each pump. So in order to make sure that doesn't occur, that simple idea of a red sticker on one chart, a blue on the other, and then corresponding red and blue stickers on the line and again on the actual syringe. And the last right of administration is that right to refuse. So we've talked about the patients giving consent. If they don't give consent, then it's down to us to find another way of managing this person's symptoms. It may be that they need a bit more information. It may be that they may need a bit of time to actually discuss it with loved ones or carers. But whatever it is, if they refuse, even though we may think that's not the right decision, that is their decision. And as long as they have capacity to make that decision, then we need to go along with that and explore that further. So this is the slide about actually inserting the battery, obviously before we turn on the machine. Always using a Duracell Plus or Ultra battery, that's really important. In the community setting, because of the way that the BD Bodyguard works, the manufacturer's recommendation is that if it's running around about 1 mil every hour, which our drivers are, then after 24 hours there should only be 50% of the battery life left. So it may not last another 24 hours. So that's why there's a slight change in that. Previously it was 40%, now we've changed it to 50%. Obviously in an inpatient unit where the battery is being checked every 4 hours, it can be left to go down more than that, else there'll be a huge amount of wastage. So in an inpatient unit we should be changing the battery when it reaches 10%. So one of the things that we've got to do with this new syringe driver is to change the time and date, and this video shows you how to do that. So once it reaches load syringe, you press the info button and go to change setup, and the code that you need to put in is 99. So if you press and hold the key, it will go up initially in single digits and then in tens. So the easiest way is to go up to 100 and then use the drop down key to drop it to 99. Confirm with the green button, drop down this menu to the time and date, again confirming, and then just using the up and down buttons to get the correct year, month and date, but with the dropping up and down buttons, and then confirm with the green button, as you can see, and then again doing that with the clock as well. And then when it's all done, you press and it gets to exit, you press the green button and it's back to the load syringe video screen, sorry. So when we're preparing our medications in our trust, there should be no more than 3 drugs in one syringe. There may be very occasional situations where, certainly if it comes from the specialist palliative care team, they may prescribe 4 drugs, but that is a very rare situation, but it may occur. We're always going to start off by drawing our medications up using either a 1 or a 2 ml syringe, depending on how much of the medication we want. And what we're going to do is we're going to draw up the required dose of medication. We're going to put it on our work surface alongside the vial that the medications come out of. We do that for each drug, and the reason we do this is because we are using it as a double checking method. So once we've drawn up each of our drugs, ensuring we've got the right drug, the right dose and the right volume, we then double check again, making sure we've got the right drug, the right dose and the right volume before we then put it into the main syringe that's going onto the syringe driver. When we're using a glass vial for the drug, we need to use a filter needle, because when you break off the lid of the vial, a microscopic piece of glass may get dropped into the actual drug, so we don't want that anywhere near the patient. So by using a filter needle, we can make sure that when we're drawing up the drugs, if there is any shards, they go into the filter needle. But then obviously we need to change the filter needle for a filler needle in order to then add it to the syringe. We don't use the same filter needle to add it to the main syringe. We switch over to one of the blunt filler needles and before we add the drug to the main syringe. As we're adding the drugs together, we need to make sure that we're visually checking that there's no reaction, i.e. the fluid's not going cloudy or there's no signs of crystallization. For our trust, water for injection is the standard diluent. So for things like morphine, midazolam, levomepromazine, buscopan, water for injection is the diluent that we would use. There are certain drugs where normal saline is required, but you would get specific instructions on the prescription to use normal saline as the diluent. Again, if you are being asked to set up a syringe driver, ensure that the prescriber not only has prescribed the medication to go into the syringe driver, but they've also prescribed the water for injection as the diluent. So when we're making up the syringe, if we're making up a 20 ml syringe, we make it up to the volume of 17 mils, and a 30 ml syringe we make up to the volume of 22 mils. And those 30 and 20 ml syringes are always going to be Luer lock. We do not use bayonet syringes for syringe drivers. The reason being that obviously it's a lot easier for the line to become detached from a bayonet syringe than it is from a Luer lock syringe. We're obviously going to make sure we're doing our checks. We're always going to make sure that the medication matches the patient's prescription. We're also going to make sure the expiry dates are well within date. We're going to prepare the medicine's label, and the medicine's label has the information of the patient's name, the drugs that we use, the batch number, the date you set it up, your signature, if you've got a person double checking their signature as well, and they're in our trust they're either a yellow or a white label. It doesn't matter what colour as long as you've got the label on with that information, and that's looked into more in the practical video. And also, because we talked about a while ago about the fact that it can take a few hours for the infusion to get to a therapeutic level in the system, if a patient has got uncontrolled symptoms, it may be that they need PRM medication when you set up the driver in order to try and cover them until the driver kicks in properly. So in this trust, we use a process where we prime the line before we put it onto the actual pump. So we prime the line from the contents of the syringe. So we do not prime the line with separate normal saline or separate water, because obviously that then means that the patient's not getting any active drugs for a number of hours. So we always prime the line with the contents of the syringe, and this will reduce the syringe contents by about between 1.5 to 2 mils. That giving line is changed when any of these situations happen. So if any of the drugs are changed in the syringe driver, we change the line. If there's any dosages, so the dose is increased or the dose is decreased, we change the line. If the line has become useless because of the drug has crystallized, we obviously need to change that, because if that's the situation, the patient isn't getting the medication at the rate they should be. And also, if the line becomes damaged, sometimes they become cracked around where the syringe driver is attached or around the patient. So obviously, if that's the situation and that line is leaking, then we need to change that line. And as I said to you, if there's any reason why you need to change the line mid, so for example, you get a call from a patient to say that the alarm's going off and it says occluded on the machine, you go out and see that patient, you look at the line and you see that the line has crystallized. You make a decision about whether you are going to change the line, but are you also going to change the cannula? But when you change the line, you prime it again from the syringe. So the volume in the syringe will again go down, but when you reset it up on the driver, that driver will calculate the new rate over 24 hours again. So you're not going to lose any of the timings or the medication, but never ever prime the line with just saline or water for injection, because it means the patient is not getting the drugs for a good period of time. So it's really important that when you switch the syringe driver on, the actuator moves to the position where it started the previous infusion when the syringe driver was last used. It's really important that you keep your fingers away from the actuator while it's doing this, because there is a risk of your finger or something becoming trapped within that actuator. And obviously you need to know what happens if this occurs. So as you can see, the first thing you do is power the pump off by holding the on-off switch. You then raise the barrel clamp arm, and then you put the power back on again. And obviously you are doing this ignoring the screen prompts, because obviously they are not, they are in relation to the alarm and not the fact that there's a trapped object. So you need to make sure that you follow this process as it's set out here, rather than as it says on the syringe driver in this particular case. Then once the syringe driver is switched back on again, put down the barrel arm, and then you be able to use the forward and back keys to be able to release the object. Obviously this is a really important safety feature, so please take time to become aware of this, so you're au fait and understand how to do it. Luckily, hopefully it doesn't happen very often, but we obviously just need to know from that safety point of view if ever it does. When I've looked at some of the incidents around syringe drivers and things that have been reported on the IR1 forms, some of the things, a lot of it is about people getting distracted. So there are ways that we can avoid distractions. I appreciate that when you're in a patient's home and it's full of very emotional relatives, then it can become very difficult to concentrate on one thing and try and shut yourself away to pair the syringe driver. But that is what your job is. You know, you need to discuss with them the fact that yes, you'll answer their questions, but now you need to go into the kitchen, you need to shut the door so that you can set up the syringe driver, so you do not make any mistakes that may be detrimental to the patient. And then when you've done that and set that up, you will then be happy to answer any questions, any worries or any concerns. And this idea comes from the aviation industry, which a lot of safety issues come from the aviation industry, and it's called the sterile cockpit theory. And the reason being is that when a plane is taking off or landing, the only discussion that is allowed within the cockpit is discussion about the taking off and the landing. The pilots can't be talking about what they did yesterday or what they did when they get home, when they went out last night. It's all about what they're doing in that particular moment in time. And I think that's a really good practice to take with things like syringe drivers, so that you can see exactly that when you're setting up a syringe driver, you are fully concentrating on what you're doing with that syringe driver. As I say, ideal situation is that you can go into another room, whether it be a spare room, spare bedroom, or a kitchen, and do the setting up of the syringe driver without any distractions. Obviously, as I said, in busy households you'll need your own strategy, but actually it is your responsibility to ensure that you are working within a safe environment, both for yourself and for the patient. So these are just a few more resources that you can look at. So the book.palcare.info is a really good website that you can look at, and it talks about symptom control, drugs, conversion of drugs and things like that. Obviously the palliative care formulary, I think we're now on the 7th edition, which is a really good resource. There's also the website that goes along with the palliative care formulary, which is called palliativedrugs.com. And then the last two references are for our own syringe driver policy. This is in the process of being updated as we speak to you now in January of 2022. So hopefully that will be done in the next few weeks. So thank you for attending this training. If there are any questions, just direct them towards your trainer and they will be more than happy to answer those questions and ensure that you're happy with the process of setting up the syringe driver. What I invite you to do now is watch the video on the practical demonstration of setting up a syringe driver, which goes literally from how to insert the cannula all the way through to attaching the completed syringe driver to the patient. And then you will be asked to complete a competency document before, and also to undertake 5 supervised syringe driver changes before you are classed as being competent to go out and do them on your own. So thank you for listening, and I wish you all the best for your syringe driver practice.